Hey everyone, welcome to the Func Med Nation podcast. I'm your host, Dr. Steve Noseworthy. The views and opinions of guests on this podcast are their own and may differ from my own. But as always, I try to be respectful of other people's opinions, even when we might disagree. All right, guys, welcome back to the podcast, or I should say podcasts, because this episode is actually going to air on both of my podcasts, both the Inflammation Nation as well as the Func Med Nation podcast. And the topic today is SIBO, which stands for Small Intestinal Bacterial Overgrowth. And I'm sure our conversation is probably going to range a little bit around just the topic of gut health in general. But my guest today is Dr. Allison Siebecker, and she's been specializing in SIBO since 2011. She received a Lifetime Achievement Award for her work in SIBO and outstanding contributions to the field from Gastro A&P. She's been teaching advanced gastroenterology at National University of Natural Medicine since 2013 and is an award-winning author. She was the co-founder and former medical director of the SIBO Center for Digestive Health at National University of Natural Medicine, and her integrative SIBO protocols have helped thousands worldwide. Allison, I have, first of all, welcome, and I'm glad we had a chance to connect. And I have to tell you that I've been podcasting for a few years now. And from the very beginning, your name was on a short list that I had written down probably 3 years ago of people that I really wanted to make sure that I connected with. And I feel bad, and I'm sorry that it's taken me so long to reach out to make this happen.
It's nice to know that I was a name on that list. Thank you.
Yeah, there you go. Well, I truly consider you to be one of the expert voices in the field. And I would say that, you are, to my knowledge, you in our world as clinicians, because SIBO research existed before, at least certainly before I became aware of it. But, as far as I know, from my experience, you were one of the early voices on the clinical side, bringing SIBO to the forefront of our, let's call it our collective awareness. And so I want to talk a little bit about your background before we get into the nitty-gritty of SIBO. And I'm always interested in people's origin stories, like how you got into natural medicine. So I kind of want to break it down into two things. Number one is, what is it that attracted you to natural medicine to begin with? And then I would like to know what was going on in your mind and in your practice that put SIBO on your radar, especially to the point where you became one of these leading voices. So let's just start with the origin story. Like, what were you doing before you went to naturopathic college, and why did you pick naturopathy?
Well, I was always interested in natural health and alternative health. I think it started for me maybe in high school, where I had some friends who were into health food in high school. Like their parents bought like whole wheat bread instead of white bread.
How strange.
And I was really attracted to that. And I was jealous that they got the whole wheat brown bread and I had the white bread. And I mean, my mom did the best she could, but she wasn't a health food person. And so I got totally into it, and I lobbied my local health food store to let me start working there. And so, and I did. And so I just got into that whole field. I had also been really into massage. And so that sort of was another sort of gateway into more the health medical world. Yeah. And then I worked in health food stores as a career. Actually, I was a manager at various health food stores before I went to naturopathic school. But what actually, made me want to go to naturopathic school is, I would say, like a calling, it was almost like a spiritual calling. I actually had an experience. I was at an herbal medicine conference, just attending that because I worked, managed in health food stores. We sold herbs and everything. And I actually had this experience where I felt like a metaphorical lightning bolt, came down and hit me. And I stopped in my tracks. I was walking, stopped, and it was like, I need to be a naturopathic doctor. I have to go to naturopathic medical school. And I'll tell you what, thank God for that. Because if I hadn't felt like it was, something divine, I don't know where people get the motivation to make it through medical school if it was just only their own ego or something, like, it's
just like a career choice, right?
Just a career choice, or just because they want a status job, or I don't know what the heck motivates people, but and I did 2 degrees at the same time. I did a master's and a doctorate, and so it was just so grueling, So thank God I had that, because it was like, well, I can't say no to, to that. So I got to keep going.
Yeah.
But,
Yeah. And that
but in
fuels the
terms of
fire as you keep going through the challenges.
Totally.
Yeah.
And then in terms of, what was I doing after I graduated, I was doing general medicine. My master's was in Oriental medicine, so a lot of acupuncture as well. But really the thing is that I had IBS my whole life. And that turned out to be SIBO not my whole life, from about when I was 5, as near as I can tell, is when I got it. Because I was born with normal, GI function according to my parents.
Yeah.
But since I was about 5, I had it and struggled a lot with it. My whole life struggled terribly with it. Saw like so many of our patient stories, saw so many doctors, tried just about everything you can think of. And I really mean that.
Yeah.
And went through medical school, still no answers. And it wasn't until afterwards when I found out about SIBO from my gastroenterology professor, was a friend of mine also, and he was writing a book and happened to have just found out about SIBO and just put like a paragraph in his book about it. And I was helping edit and review his book. And I was like, what? And I went and looked it up and just went down a rabbit hole. And it was hard back then. I mean, that was like 15 years ago. But then again, another sort of fire got lit in me. Really what did it for me was when I tried a treatment for it. I actually started with diet. I tried diet for it. I tried the specific carbohydrate diet, SED for short. And within 24 hours, my pain that I had suffered terribly with abdominal pain was gone. And so you can imagine how that would light a fire. I just thought about all of the patients and people that I know with IBS who struggle. And to think that they could get that kind of relief, overnight, then that's what lit the fire for me to want to raise awareness. And yes, I sort of took it on as my job to raise awareness of this because nobody knew.
Yeah. And I think, that there's some elements to the origin story that I think we kind of all share. And I won't bore you with my own, but, I was dealing with some orthopedic issues that surgery and steroid injections and different things didn't fix back when I was in my 20s. And someone suggested, well, why don't you go see a chiropractor? And I was like, well, and I'd never seen one before, right? And so I had that personal experience that just changed my life. And I thought, well, and at the time I was living and working in downtown Toronto. I'm Canadian originally. And I thought, well, how neat would it be if I could change somebody else's life the way that this guy changed mine. And,
that's exactly it.
But I think that that's a very common thing. Now, I do remember, like, when I was in first year at Logan Chiropractic College in St. Louis, one of our early instructors in the first semester asked for a show of hands, like, how many of you are here because your dad's a chiropractor, your mom's a chiropractor, your uncle, and about half the class raised their hand and the other half didn't. And he said, this is quite interesting because 5 years ago, everybody would have raised their hand because, being a chiropractor, you were kind of raised with chiropractic or raised as chiropractic family. And he said, it's an interesting shift that now people are starting to choose chiropractic just simply out of an array of different professions. Right. And so it makes sense to me because I had wanted to ask you the question, like, why did you pick naturopathy versus acupuncture? And I know that you're a licensed acupuncturist as well. Now, I'm assuming that came later.
No, right at the same time. Well,
at the same time.
Well, where it came was, you're right, though. The desire to do it came when I was in naturopathic school, and they had a program, and we all have to take some Chinese medicine classes anyway in naturopathy. Yeah. And then, then I just decided to do it, and so I just did it together. But you're right, that desire came later.
Yeah. So let me ask you to do this because we're bandying around because this podcast is going to go out to the general public as well as to clinicians. Define naturopathy and maybe distinguish that between a more umbrella term of a natural medicine doctor, because we use these terms kind of like interchangeably. And I might tell someone I do functional medicine and they think I'm a naturopath, right? So what, like, just as succinctly as you can, let's say you're talking to general public, how would you define what naturopathy is and what you do as a naturopathic medicine doctor?
Yeah, it's a similar training in sort of what you see in the books as the basics to an MD, a medical doctor. And it's its own degree. It's its own, school training and degree. But it's a similar base training. But then in addition, we add in things like training in different, basically we would call treatments or modalities. So we have training in actually manual adjustment. We only do a year. So, I personally send everyone to a chiropractor who's had their 4 years, Yeah. So we have some manual adjustment training. We have homeopathy. We have herbal medicine or botanical medicine. We have actually hydrotherapy, which is like use of hot and cold, various sort of old school home treatments that, things like that. We learn physical medicine, like using TENS machines and things like that, some sort of sports medicine. And we also, like the base training, we also learn pharmaceutical antibiotics. So we have the same base training, and we also learn minor surgery. So the same base training is there, but then we add in the natural modalities. And of course, nutrition and diet is highly stressed, as well as like lifestyle. But we take all the same pathology classes and all that. But we have different modalities, and we also have different philosophy. And we actually have classes in like natural medicine philosophy, first do no harm, really bringing that through. How do we really bring that into our practice? And then I think the other thing I would say is that the ability to practice is different state to state, but for naturopathic medicine, there are states where we are licensed primary care physicians, which need legally to be covered by insurance. Sometimes they try not to. And then also we can prescribe, not in all states. But so that is one thing that's a little different from maybe like a chiropractic degree. I don't think there are any states where chiropractors are allowed to prescribe. Is that right?
There are some very forward-thinking states and state associations like there, and I want to say it's Arizona can do some injections.
We can prescribe any medicine, like just anything, any antibiotic, and we're trained in it. So in that way, it's kind of like the best of both worlds. But what we don't do major surgery. We do only minor. So we don't go below a certain level. We're not working in hospitals doing major surgery. So, and we don't have the same, we have some specialties, but we don't have the same specialties. So, so think of it as like you're getting your basic training, but you're getting all your natural training too. So it's a wonderful thing. And functional medicine, that gets confusing too, because I think where that was originally created for MDs who wanted, after they've gotten their MD, they're really attracted to natural medicine and they want to incorporate more of that. And the big thing there is that MD has quite an emphasis on structural organic problems, missing out on some of the function of the body. And that's where the functional medicine came in to sort of fill that gap,
Yeah. Well, let me ask you about that, because I've asked other clinicians and say subject matter experts, like how we can go back to Jeff Bland's original paper on functional medicine and kind of the rules and the tenets of that they developed. But functional medicine, I think, the term is used very loosely to describe many different things. And you can have two clinicians that say they do functional medicine, but they actually do two very different things. How would you describe that? How would you, like, if you were to put pen to paper and outline a framework, this is what functional medicine is. What is it? And in your opinion, how does that differ from, let's say, the basic philosophies and principles of naturopathy?
Well, I haven't gone through the Institute for Functional Medicine training, but from the outside, what I can say, and I've taken classes from some people who are functional medicine teachers. So, I'm not sure if I've got it right, but what I would say is philosophically, functional medicine is really trying to focus more on root causes, identifying root causes, which, that's the huge criticism in MD world is this, it's more about fixing the symptoms, right?
Yeah.
And also trying to restore function back to normal as best as can be. And so that's where they may use different test positive criteria, not just what gives you the disease, but looking at opening those levels a little to say, what's the pre-disease? Let's get you before you get all the way there. So prevention, function, really making sure how well is your thyroid function? How well is everything functioning? Things like that. And, I guess the difference is that naturopathy, of course, we have root cause built into everything.
Yeah.
We have both structure and function built into everything. I think it's probably more so the modalities. Like, I think a typical functional medicine practitioner would have been an MD that wouldn't receive extensive herbal medicine training or homeopathy training or things like that. But then they may learn some of that later. They learn a lot of nutritional supplement, I think, in the Institute of Functional Medicine. Of course, we learn all that as well. So maybe there's just some modalities or treatments that aren't quite incorporated in to functional medicine, but could be, if they have classes in that.
Yeah, and there's certainly a lot of crossover. And like if you could create a Venn diagram of all the different natural medicine disciplines, there would be a lot of intersection, right? But then there would be some things that might be specific and unique to one particular discipline that you typically don't see in the others.
Yeah, and I just want to say that just generally for me, all of these distinctions, in my mind, I don't care so much. I mean, what matters to me is people have good training and have goodwill, good heart, and, are trying to help people. And, we've all met any discipline can have people that meet those criteria and are doing a phenomenal job and are not annoying, and then every discipline can have people that, you're disappointed in. So,
yeah, I look at things I look at human function on a spectrum, and I think it's a note to the amazing resilience and flexibility of how the human body is framed and designed, that sometimes it doesn't take much of a change or an input to course correct. But then as conditions evolve, as cases become more complicated, it takes a lot more effort, right? And again, I go back to some of my early stories when I was being trained in chiropractic. We had this one he was an old, I'm going to call him a geezer. At the time, he was probably no older than I am right now, but that was a while ago. And, he said, some people you just need to hit them in the butt with a broomstick and they're going to get better. And, I see that in some of my own clients is that sometimes the only thing I really needed to do was maybe optimize their diet, or if we need to do supplementation, it doesn't take much. Like you're not taking 6 different formulas 3 times a day for 12 weeks to make something shift and change. But then there might be some cases that do require that. And so there's like this huge wide range of different case presentations. But I like these conversations about things like principles and concepts. And because I've always attributed this next question I'm going to ask you to naturopathy. And I don't know if I should. I'm sure the concepts kind of predate what we consider to be modern naturopathy. But there's this, again, I'm going to say old naturopathic principle that says that health begins in the gut.
Yeah, and, you sent that to me ahead in an email. Yeah. And when I thought about it, I thought that is so great, because the saying I think that I've heard that is attributed, who knows if it's true, to isn't it Hippocrates, is all disease begins in the gut. And I like that you flipped it. All health begins in the gut. There you go. Prefer that.
Yeah, well, that just underlies the difference in how we're trained to think, right? Because when I work with my own clients, I don't think that I'm certainly not treating disease. I'm trying to find out where people have lost wellness and how to restore that. Right. That's the way my mind works in terms of, what it is we're doing in an exchange with, clinician and patient or client. But I want to ask you about this idea, because there are a lot of, and I'm going to use loosely naturopathic and functional medicine kind of interchangeably, because there is a lot of overlap. So forgive me if I don't want to step on any terminology.
No, it doesn't bother me at all. I don't care about linguistics.
Yeah, there you go. So, I know that there are a lot of docs that no matter what walks into their office or what someone's clinical presentation is, or really what their underlying true causes are, they're so convinced that health begins in the gut that that's where they start every single time. Now, I'm not judging whether that's the right or the wrong thing to do, because I think that judgment has to be done on a case-by-case basis, mixed in with how the clinician thinks. But let me get your take on that. As someone who's been trained differently than I, is that what you believe clinically? And again, I'm not judging one direction or another, but do you think that that's always a good thing to do, is to figure out what's going on with the gut and to fix that?
I can't imagine it's always the right thing. Yeah. I mean, I've heard other sayings that people in their own disciplines say all disease or all health begins in the thing they specialize in, right? So, yeah. But I can say that there is a lot of truth to it. And, SIBO is a fascinating example of it, in that when we take a look at, I have a free educational website. And one thing I do is I every time there's new studies come out, I do it quarterly. I add them into this associated disease list. And the associated disease list is like massive. And what I mean is that SIBO has links with diseases in all parts of the body, neurological, kidney, cardiovascular, and, atherosclerosis, and liver, and skin, dermatological,
right,
mood. It goes on and on and on. So I can see the underpinning of truth in that statement for sure, even just looking at SIBO. But I can't imagine it's always the way to go. I think people have their own ways to practice, where they like to start, and I think they develop that over time. And everybody has to follow their own medical intuition with what they want to do.
Exactly, and I totally agree with that. I absolutely agree with that. And I thinking about we're going to have a conversation coming up here in a little bit about causes and consequences of SIBO. Right? Because if somebody has SIBO, something caused it. And if we're really, truly concerned about root cause, the question we're asking is not simply, do you have SIBO? How do I treat it? It's, oh, you have SIBO. Why do you have SIBO?
Yeah.
Right? Because, one of our, and I would say we're probably pretty close of the same mindset, that if we were to critique the medical approach, the pharmaceutical approach to SIBO, it's typically, a round of antibiotics or so, and not necessarily any other changes. And that might depend on the knowledge base and experience of the prescribing physician. But the mindset is typically, well, you've got these infections. Let's use antibiotics to kill that, and then we're done. We kind of wipe our hands and walk away unless it recurs, and then are going to see you in 3 months or 6 months down the road. But never in that model or that approach is there this question about what's causing the SIBO. And if you don't mind, let's put a pin in that and come back to it, because I think it's a great conversation, particularly for the clinical side of things. But it might be helpful for anyone out there listening who's not a clinician, who thinks they might have SIBO, who can look back in their own history and go, oh, maybe that's why. And I want to keep going, but let me just pause, because I do have a couple of other questions just in terms of the general realm of discussion before we get into details. I'm always interested in how other clinicians explain things, especially complex things like SIBO, to their clients and their patients. So I want you to pretend that I'm a prospective client. I'm sitting in your consult room. You walk in, we meet for the first time. You go through my history. Maybe I've got some labs, maybe I don't. And you start thinking in your mind, okay, I think Steve's got SIBO. And then you bring that up and I say, SIBO, what's that?
Okay, now I have to tell you something funny. I'm going to answer the question, but I've been a SIBO specialist since I started in SIBO. When I was a specialist. So everybody who came to me already knew what it was. But I have an answer. And here's how I would describe it. So, but I'm lucky because I didn't have to have that first conversation, right?
Yeah.
I would say, so it's small intestinal bacterial overgrowth, and that it sounds like what its name is, in that bacteria we don't typically have a large amount of bacteria in our small intestine. The place for that is the large intestine. Most people know we have, a microbiome that's beneficial in our large intestine. So that's good. But typically in the small intestine, we don't have a very large amount. And so what happens is there's like a colonization or an overgrowth of bacteria there, and they mess with the structure and the function in that area. And the function is to digest our food and absorb our food. And so the bacteria just wreak havoc with that. And they mess up all of our digestion and absorption. And they also mess up the structure. They cause damage to the lining of the small intestine. And so once again, that has ramifications on what we're absorbing. And it also leads to a whole bunch of symptoms, because we're not supposed to have this amount of bacteria there. And it's just not the place for them. It's kind of like a location, right? In real estate. So then we get all these symptoms like abdominal bloating, bowel movement changes, pain or discomfort, and the list goes on. So that's basically it. They shouldn't be so many there. They've had the opportunity to grow there. We haven't talked about why, and we need to reduce that.
Well, that sounds great, Doc. How do people get SIBO?
Great, let's move into the conversation. Okay, but instead of just doing it right, like to a patient, I want to tell you something a little bit more background, which is that I like to think about it in two levels. The physiologic underlying causes, meaning what's gone wrong in the body to allow it to happen. And then for now, I'll just call it the causes or the risk factors. So these are like the diseases and things that lead to it. But if we think about it in the body, we have a lot of protections naturally that make it so we don't get this. I mean, this is not the way we're supposed to be. And they've been able to figure out really the most important one is this movement or kind of form of peristalsis in the small intestine, the migrating motor complex. And it doesn't actually happen with food. It happens when we're fasting, and it's called the housekeeper wave because it cleans up after we eat. And one of its main functions is, besides like sort of cleaning up, is to sweep bacteria on a regular basis away down into the large intestine to be excreted, keeping it clean. It's just like constantly sweeping away whatever bacteria are accumulating. And we now know that this is one of the main reasons why people get SIBO is this becomes deficient. We don't have as much sweeping, cleaning action. And that's really the main underlying cause physiologically of SIBO. And so what would then cause that would be really anything that could damage the smooth muscles or the nerves that create this movement. And it's a large list of things, But I can tell you some of the most common. The most common of all is food poisoning, also called traveler's diarrhea or stomach flu. But really here we're talking about bacterial food poisoning because food poisoning it's most common from virus, norovirus. But this is not that. This is bacterial food poisoning. And as you know, this pathophysiology sequence has been figured out. And basically what occurs is an autoimmune situation is triggered, unfortunately. And the body damages its own nerves that create this migrating motor complex. And then those waves diminish. And just think of it sort of like this. This is a great analogy for, just non-practitioners as well, is think of it like a flowing river. When a river is flowing, there's not much chance for bacteria to accumulate. But if it becomes stagnant and still, we know bacteria overgrow, it becomes like a swamp. So it's like that. If it slows down, bacteria overgrow. And the small intestine is a dark, warm, moist environment. So without much movement, there you go.
Yeah. Something's going to grow.
That's sort of the main thing. And then I can say the other risk factors for the slow motility, but let me just say the other sort of key physiologic reason would be something anatomically, structurally wrong or not normal, we'll say. And the most common for this would be an obstruction, or really here we're talking about a partial obstruction. And here we can sort of think about it like a log jam in that same river analogy. If some things pile up in an area in the river, stuff's going to back up behind where those logs are. So just physically. And so this can be things like strictures, that's a narrowing of the intestine. It could be a volvulus, which is a twist or a kink. It could be a tumor. It could be a compression, an area something's getting compression. And most common is adhesions. And adhesions are scar bands. They're a repair substance. They're supposed to be helping, but sometimes they can form in such a way where they compress parts of the small intestine, causing a narrowing. And then, if you have an area like this, the river can't flow as well, and stuff can back up behind it. And so, you'll get an area of narrowing and an area of dilation above it. So
can I interject? I'm sorry to interrupt, but can I ask two questions that are just relevant to things that you're just saying? First question is, and I'll put them both out that we can just answer them one at a time. On what percentage of cases that you're dealing with that you're seeing a history of food poisoning? Because I have that. I routinely ask that in my intake form, especially if they have gastro symptoms that I think look like SIBO. I'll ask them, have you ever had a viral gastroenteritis, ever had food poisoning? I don't always see it, but I don't know what the percentages would be. I'd be interested in your feedback. And the other thing about the scar tissue, I know that abdominal surgery is a risk factor for SIBO.
Yeah.
And abdominal surgery doesn't necessarily mean intestinal surgery.
That's right.
Because I've seen some papers that have, looked at scar tissue post-hysterectomy, for example, or post-gallbladder removal. Well, technically that's kind of intestinal because it's the GI tract, but it doesn't have to be, I had surgery on my bowels and that's where my
anywhere
scar
in the
tissue
abdomen. Yeah.
Yeah. Okay. So that answers that question. And what is your impression of what percentage of all SIBO cases you see have a history of food poisoning that you think is causative?
That's the majority. So, I was a SIBO specialist. That's all I saw. And, at least 60%, I would say.
Okay.
And here's the key thing to note is that many people do not remember having food poisoning who actually have food poisoning as their cause of SIBO. So it's vitally important to ask it in history because you're going to grab the most people that way. However, particularly in mystery cases, very often when you really can't figure out what the underlying cause is. And by the way, this is not the easiest thing to do. We haven't really talked it through, but there's a huge list of underlying causes of SIBO, many of which are specialty fields in and of themselves to learn how to diagnose. So it takes referrals. It's not the easiest thing. It's very easy to say, find the root cause, and we need to try, but it's not so easy to just whip that out,
Right. Agreed. Agreed.
Yeah, right. So it's important to know this so we don't get, whatever. But we do have a test that's a blood test that checks for this particular cause of SIBO. And in cases where I can't figure it out, I've run this very often. I run this and it comes back positive and the person has no memory of having food poisoning. And that's because, contrary to popular belief, food poisoning can occur with mild symptoms. We all think of the, both ends, coming out both ends, horrible. You wish you could die, just awful. But it could just be some mild soft stool one night and you don't think anything of it. That actually can correlate. And so I've seen that very often where people don't remember. And one other thing is that the cause of food poisoning, it can move from food poisoning, the symptoms can change and move right into the SIBO IBS symptoms, and you have SIBO. But more commonly, there's a delay. It takes time for that nerve damage to occur from the autoimmune damage, and it's typically 3 to 6 months after. And so if it's 3 months after, people are not linking it. Doctors are not linking it. And so that's a key thing to note for people is that.
Yeah, and that's, I think, one of the things. It's not
like one right after the other.
Yeah, maybe a failing in our collective approach is sometimes we're looking for the cause too proximal to when we're talking to somebody. Like we don't go back 10 years, 20 years, or whatever the case might be. So I'm interested, what test are you running if you have this like a mystery case? What test do you use?
Yeah, so this test it's generally called the IBS blood test, but some of the specific labs are IBS Smart is the main test. This is the second generation version of this test. IBS Smart. There's also IBS Check was the original version of it. And then I think Vibrant America and Vibrant Wellness and Cyrex have their own versions.
So you're looking for antibodies to cytolethal distending toxin. Is that your approach?
Yeah, we didn't explain that, but this is the toxin that all the bacteria that cause this food poisoning, they all secrete the same toxin. So we're looking for antibodies against that and also antibodies against the protein that's on the nerve cell that the immune system is damaging, and that's called vinculum. So antibodies against vinculum. So that's what this test is. It checks for those two. And there's a different prognosis depending upon which is positive. Vinculin is the sort of more severe form of it when that's positive. But it lets us know if this is the cause of SIBO. There are many other causes, right?
Sure.
But this one, and also this will also then let us know that it's the migrating motor complex as the actual physiologic underlying cause, because that is what occurs in this pathophysiology. Doesn't mean there couldn't be other things too, but
no, and it's probably also good to point out that you can have more than one cause.
Yeah.
Right. There's no rule that says,
like that.
Thou shalt only have X and you shall not have Y. Right?
That's right.
Yeah.
And I have many patients like that. They have like 3 or 4 main causes of SIBO.
Yeah.
So maybe I'll just quickly mention a few of the others just so people can get a smattering idea.
Please.
So inflammatory bowel disease, that can cause strictures and all sorts of structural problems. Diabetes, that can cause nerve damage, which can damage the migrating motor complex. We know that many people with diabetes get gastroparesis within like 5 years of their diagnosis. Gastroparesis is slow stomach emptying, and there's a migrating motor complex that begins in his stomach. So that sort of automatically affects that. Hypothyroid, of course, has slow motility. We know constipation, but it affects the migrating motor complex.
Right.
Ehlers-Danlos syndrome. These are all diseases. Ehlers-Danlos, I don't know how familiar everyone's becoming with it. It's like newer within the last 10 years to many of us, but it's not rare. And it can have both structural components and migrating motor issues. It's a double whammy. Many people with a very high percentage of people with Ehlers-Danlos have SIBO.
And one of the aspects of that is just let's say weakened connective tissue, right?
Yeah, and that can cause prolapse in the intestines and sort of almost like blind loops and twists and kinks and things.
Yeah.
Parasites, we don't have a lot of good literature yet, but we're pretty sure it slows the migrating motor complex, various infections. Some classic sort of risks are like hypochlorhydria. That's one of the body's protections. So many people have hyperchlorhydria. And then, of course, there's medications like proton pump inhibitors that on purpose cause hypochlorhydria. So they're a risk factor.
Right.
Other medicines would be opiate narcotics. They cause constipation, painkillers, but they also slow the migrating motor complex.
Right.
And even antibiotics have been linked with slowing the migrating motor complex. We use some pharmaceutical antibiotics for SIBO, and they work, but there are some antibiotics that could potentially slow the migrating motor complex. And this is important because so many patients come in feeling that medications like this, and including antibiotics, were what caused their SIBO. And so there's some truth there. And then we have things like traumatic brain injury. This is considered to be an epidemic these days. That can slow the migrating motor complex. Parkinson's disease, one of the first signs is constipation and slowing of the migrating motor complex. We have Lyme and co-infections, slow the migrating motor complex. And then we have, generally adhesions, things that cause that, things like endometriosis, very high degree of SIBO in that. Appendicitis. People can have smoldering appendicitis, not just even acute, where it gets removed. And as you mentioned, abdominal surgery, radiation. But honestly, adhesions can be caused by, infection. So that'd be like appendicitis. Inflammation, same thing there. Or injury. And so a lot of people have abdominal adhesions from sporting accidents or just, living their life, falling off a bike. Car accidents, you can get them from many, many reasons. And that is probably our second most common cause of SIBO across the board, I'd say. I'd say that adhesions, abdominal adhesions. Yeah, which, people are not thinking about.
No,
and I'd
not
say
really.
maybe right. And I'd say the third most common cause would be all of these diseases I'm mentioning and medications, like is a clumped risk factor. So, and one last I must mention is mold, toxic mold illness. This is another thing many of us have learned more about in the last, 5-ish years. We could say there's an epidemic of that, water damage in homes, work buildings, cars, and mold illness also slows the migrating motor complex. And mold illness is what's typically involved. One of the first things we think of when we have a very challenging, tough case of SIBO. And actually, while I think of it, there's one other thing I want to mention. You talked about finding the root cause and the relapse rate. And I just want to say that from the studies that have been done, we know that SIBO has a very high relapse rate. It's about 2/3 of cases will relapse, that'll just come back. Reason being
and that's independent of the treatment methodology, because I would imagine relapse rate is higher with certain treatments than others.
No, that is not true. All treatments have equal efficacy and equal relapse rates, near as we can tell.
That's a new thing for me.
Yeah, all the treatments have the same success rates, so they all work equally. And but just briefly, what are those treatments? Pharmaceutical antibiotics, herbal antibiotics, and elemental diet. They all work equally well, and relapse has nothing to do with that. What the relapse has to do with is there's an underlying cause there. Like everything we just mentioned, diabetes. There is no known cure at this time for diabetes. It can be very well managed. Ehlers-Danlos, same thing. Food poisoning, same thing. There's no known cure at this time for the autoimmune damage that is triggered by that. So there are many chronic underlying causes. There are other causes that can be gotten rid of. Lyme and co-infection, that can be gotten rid of. And many other things. You can stop taking opiates, but we have to look for these things. And there are a lot of underlying causes. So that's enough for me.
No, it's a lot. It's a lot to think about. So back to the adhesions and scar tissue. Are you doing any imaging? Like, can we see this on MRI, diagnostic ultrasound?
Such a good question, because The best test for this is actually a barium swallow with follow-through. And this is considered to be an outdated old test that's fallen out of favor. And everybody wants to do MRI or CT first. And what I would say is, if your doc wants to run those tests first, fine, and your insurance will cover it, fine. Let them do what they want to do. But eventually, you're going to need to come to the barium swallow. This is not a barium enema. It's a barium that you drink. And the thing here is that it actually needs special instructions because most radiologists they don't want to do this test, and they'll just take 5 films, 5 images, or just a few. So I would encourage anybody, if you're going to ask for this test, to write an instruction or ask for this so that the radiologist knows what to do, which is rule out adhesions with multiple spot films and positional changes to visualize each segment of the bowel. Then they will take like 30 films and give you, and they know what they're looking for now.
Yep.
But adhesions can be seen on a barium as right angles. And the radiologist will do the interpretation. We don't need to know how to do this. But just for, the bowel always has curves. But if there's right angles, that's how they'll know. And the other thing they'll see is an area of narrowing because they can see the white barium with an area of dilation above it. Yeah. And they'll let you know. So that's
I'll tell you, like that tip right there is gold.
Yeah.
So did you go through a period of time where you're looking at MRIs or diagnostic ultrasound and it just couldn't find what you were looking for? Or how did you stumble on, I'm going to do barium swallows?
Oh, I'm so lucky because we have our lead researcher in SIBO is Dr. Mark Pimentel. He's out of Cedars-Sinai in Los Angeles. And of course, we're colleagues and friends. And he is the one who told me, he's the one who's been teaching so much of this to all of us. So he had spent years figuring this all out. And it was from me talking to him and also the head radiologist who they called they had a name, something like something whisperer. I can't remember. Like he was so good at reading the images. And I spent time, with them, following both of them in clinic and spent more than a day with the radiologist. And I asked them for their advice. How can we get local radiologists to get a good test? And I just took what they said and put it into that little saying I gave you. I sort of made up that little saying from their advice, Yep. So it was Dr. Pimentel. He's the lead in SIBO, and he says you need a barium. That's how you're going to find this. Yeah. So thankfully, he gave me the shortcut.
There you go. Just thinking about how things have changed over the last decade or so. Like when I first heard of SIBO, I thought, oh, that's interesting. I don't think I have any clients like that. And then I started to pay attention, and then I started going like, forgive the language, holy crap, everyone's got SIBO.
Totally, right.
When you start, and I'm just wondering, first of all, is that a common experience for clinicians, is to all of a sudden something just clicks that light bulb and all of a sudden you're seeing things completely different? And, I've been doing this long enough that I know I'm not making it up in my head, but I just wonder if there are detractors, like, how for many, many years and still today, some clinicians, mostly on the conventional medicine side, say leaky gut's not a real thing.
Yeah.
Do we still have SIBO resistance? Like SIBO's not a real thing. That's just IBS. That's all it
still exists. It's kind of crazy, but look, things take a long time in the medical field to get adopted. And actually, it's not the worst thing because you have to have a lot of studies to prove it. I'm good with that. I like that. Make sure there's enough evidence. This scientific debate needs to go on for some time. I think I would say, though, that at this point, we have an overabundance of evidence, and it's a little bit over the edge now, the people who are still saying that. But what goes on is they haven't read all the evidence because they're already opposed to it. So they're not going to go and read about it. So so then what changes their mind? I don't know. I wish more people were like you, where they had the click and go, oh, but yes, of course it's common because look, everybody's overwhelmed in life and we have so many things coming at us. If something new comes, it's going to take a little while till we can integrate it and decide what we think about it. So it's common. And I just wish more people would get that realization.
Yeah, have that, the aha moment. We've been talking about SIBO, but I know in the literature, there's other terminology like EMO, intestinal methane overproduction, or ESO, ISO, sulfide, hydrogen sulfide overproduction. And it's been a long time, but I do remember seeing at least a couple of papers that talked about fungal overgrowth or SIFO.
Yeah.
Is it useful to make these distinctions, even if it's just to sort out our thought process, or even better yet, to guide clinical decisions, or practical enough that we can just kind of lump all of that into this overarching concept of so, even though it might not actually be bacteria?
I know. I sort of feel like both of those are true or good. I still use SIBO as sort of an umbrella term to mean all of it. But let me just quickly define it. So we've already defined SIBO. EMO is intestinal methanogen overgrowth. And so basically we have a few types of SIBO, and these are based on the gases that the overgrown microbes make: hydrogen, methane, and hydrogen sulfide. And then we can have mixes of those. And the methane SIBO, we found out, actually, we've known for quite some time, it's not actually bacteria making them, it's archaea, which are also called methanogens. And so this is just a technical linguistic primarily thing, which is that it's not correct to call it bacterial overgrowth because they aren't bacteria. So no matter what we think, the name kind of had to be changed because that's not technically correct, even though I still sort of refer to it as SIBO, methane SIBO,
Yep.
But so intestinal methanogen overgrowth. And then similar for intestinal sulfide overproduction, ESO is a new term, because there our bodies make hydrogen sulfide gas, not just bacteria. It's bacteria that is making this. And so that's confusing because people look in the literature, they hear about hydrogen sulfide SIBO, they go and read a study that's talking about the benefits of hydrogen sulfide and how it helps things. And then they get really confused. And it's because it's when it's overproduced. We can all understand that concept. Normal amount that's healthy, too much, not healthy. So that's why I think they made that terminology, overproduction. But back to the other point, it is also helpful for our mindset because the treatment is different. That is a key thing, is that particularly for pharmaceutical and herbal antibiotics, we choose different ones of those based on the gas type. And that's a crucially important point that causes some of the biggest trouble in treating SIBO when people aren't educated. They just think there's one thing they can use for all the types of SIBO.
Right. And maybe we can come back to that because I think before we get there, can we talk about the testing? And I know before we started recording, we talked about testing very, very briefly. But I have for a long time operated under the understanding that there was a very high false negative rate in SIBO breath testing. And I'll ask you to explain that here in a second. And so I traditionally have relied more on symptomatic response to dietary change to either affirm or deny SIBO, insert any other linguistic term you want. And that's from a practical standpoint, that seems to have worked out quite well. I feel like I have a decent track record and success rate. I don't fix everybody. I would never claim
Nobody does.
Yeah, I would never claim that. But I have steered clients away over the years from spending money on the breath test because I felt I could get good clinical guidance just simply by changing the diet for, say, 3 to 5 days and then monitoring the response. And if I had any confusion, we would put some foods back in and see what happened. Now, having said that, it almost begs two questions. What is the current understanding? Because my MO right now is based on things that I learned 10, 12 years ago-ish, somewhere around there. And I understand like research changes on a consistent basis. And so I'm interested to hear from you as the expert. What is the current state of understanding of the value of testing? What tests are best? What are we looking for? And what direction does that lead us in? And then that will lead into perhaps a discussion in terms of effective treatment. So why don't we just start there? Let's just talk about test or don't test. Like, is it sufficient to just change the diet and see what happens to bloating and distension, for example?
Well, clearly, you have a method that's been working clinically. So I would never want to encourage anyone who has a successful method to change it, right? And so we also have to think about the nature of our practices because I, as a SIBO specialist, was pretty much always seeing people who had already undergone treatment and failed. Diagnosis and treatment and failed, right? So that puts me in a different category. I'm not the first line. I mean, occasionally somebody would come to me right away just because they think they had it and they know I'm a specialist. But so really the role of a specialist is quite different. And at that point, testing is always involved because patients are absolutely demanding it. It can be the opposite when you're the first line. They do not want testing, right? And they're mad even that other doctors have suggested it. But at this point, it's like, it's all about the testing because we absolutely have to figure it out. I'm the specialist. I have to know exactly what's going on, etc. So putting that in context, I always test it. Now, in terms of what's changed and what's new, well, maybe I should give you the basis first, like with false negatives. Here's what we know. There are different substrates that are used for the test, and these are sugars that are meant to feed the bacteria. Bacteria eat carbohydrates, sugars, and turn them into gas, ferment them. And that's what we're testing in the breath, the hydrogen, the methane, the hydrogen sulfide. Most tests check for hydrogen and methane. There is one test on the market now that checks for hydrogen sulfide additional, and that's called TrioSmart, similar to that Idea Smart, same company there, Gemelli Labs. So these sugar substrates, this is where there's been a huge debate over all the years. And glucose is the one that's used most often in research. That's fine for research because basically the issue is it absorbs into our body out of the small intestine within about the first 2 to 3 feet of small intestine. So it is only able to check for SIBO or any of the others, overgrowths, in the top 3 feet of small intestine. SIBO is most common at the end of the small intestine. The small intestine is 18 to 25 feet long. Yep. So this is a test that has very high false negatives, meaning like because it can't even test the rest of the small intestine. So you can get a negative test when you actually have SIBO. So for this reason, most of us clinicians don't like glucose. Researchers like it because they just absolutely know for sure if the SIBO is there, it's right there in the top of the small intestine. So we use lactulose. Lactulose is available the entire small and large intestine. That's actually very important because one thing I didn't mention is the methane overgrowth and the hydrogen sulfide overgrowth can overgrow in the large intestine as well, not just the small intestine. So when we do a 3-hour test with lactulose, we can also see what's going on in the large intestine. It's extremely helpful. So now back to what's...
Can I ask one question on that?
Yeah.
It's my understanding that the lactulose, does that not require either a medical doctor to request or someone like yourself who's licensed, like as a chiropractor? And it's been a while since I've looked at this testing, but can any clinician of any credential, chiropractor, acupuncturist, naturopath, whatever, can they order a lactulose breath test with TrioSmart, or does there need to be a different type of licensed clinician to order that for us?
Yeah, this is such an important point. Lactulose is a prescription in the US. It shouldn't be. It's kind of a mistake that it's on there. There's no reason for it to be. However, it costs millions to get anything off of that formulary. So that's never going to get done. Who's going to pay for that? So it's very frustrating. However, there's plenty of workarounds. Genova Labs and all the places you can get the Genova test, like Rupa Labs, True Health Labs, Direct Labs, they all they have a physician on staff. That will handle that. And so then anyone can order that. And TrioSmart also just contracted with a group that's doing that.
So that must be recent. That must be recent because I was looking
3 weeks ago.
I was going to say, I was looking at this 2 months ago. Yeah.
Yeah.
That's good. That's really good. Yeah.
They had it originally when they first came out, and then whatever service they were using, I guess they had to stop using, and now they've offered it again. Yeah. But what I would also say, there's plenty of ways for those in the US to, like I just mentioned, to get lactulose, but a second option would be fructose. You can also use fructose. Lactulose is a little bit better. It's more sure that it's going to be there the whole way. Now, what's changed is we should be soon having sort of like a big article coming out all about testing, sort of settling this debate. We've been waiting for this article to come out. It hasn't come out yet, but what's changed is that there's been deep sequencing now done in the small intestine, correlating that with lactulose and culture. And I know I'm getting technical here, but actually some new techniques had to be developed for actual sampling in the small intestine. It's difficult to do. You need to protect your sample in a special way because it can get contaminated with oral bacteria on the way back out. And also you need to release some of the bacteria that are stuck in mucus. So Dr. Pimentel actually developed and then validated this new sampling technique, then used deep sequencing and compared lactulose breath test to culture to deep sequencing. Because the issue in the past was that people didn't think the breath test was accurate enough because they were comparing testing to culture. It turns out culture was not a good gold standard. We call it a tin standard. It had a lot of problems. Now with these improved techniques and with the DNA sequencing, now the lactulose breath testing is lining up perfectly with the deep sequencing, showing that the culture test was the problem.
And when you say culture, you're not talking culture from a stool sample, but from endoscopy.
From the small intestine, from endoscopy. Right,
small endoscopy.
To actually try to find the overgrowth. And you can also imagine there's issues there because where is it? I mean, we talked about the 25 feet. Where are you sampling?
There's almost like this assumption that a bacterial load is evenly distributed throughout the intestine. And, if you stick a claw down there and try to take a sample, you're guaranteed to get a hit. But
and
that's
you're not.
true. No, that's not true at all. And this is like, prior to this, we saw this with, say, H. pylori, right?
Right.
With endoscopy and biopsy for H. pylori. Oh, biopsy said I didn't have H. pylori. Well, you didn't have it in the spot that they biopsied.
That one spot.
Can say. That's all we can say.
Yeah, so it's issues. But the reason I brought that up is just because you've asked sort of what's changed. And there has always been a big controversy saying glucose test was actually better. And the reason why is it lined up with culture better. But there's this massive false negative with glucose. And so people were worried based on the studies about lactulose. But what I can say is clinically, lactulose is absolutely the one to use. Now, as to the importance of doing it, I personally would find it very difficult to not test because I'm basing my treatments, so long as aside from elemental diet, because that works for all types, on the gases. And what I find is you can't tell based on symptoms which gases are there. Because we typically have a pattern where we say diarrhea is correlated with hydrogen and hydrogen sulfide. Constipation is correlated with methane. But what we actually see clinically is if we just look at, say, hydrogen sulfide, it's about 50% of the time constipation and 50% diarrhea. Even though the studies say diarrhea, clinically, we see 50% of the time constipation. And then we see all the time where people have sort of like a pattern that doesn't quite match with that hydrogen, methane, diarrhea, constipation. It happens a lot. So we can't really just tell, oh, you have constipation or you don't. Really, the issue is you don't have constipation, so you don't have methane. That's really where we get into the trouble. So by doing the breath test, you can see the exact gases, and then also you can see how high they are. So it's not a yes and no test. It's a real informative test. And when we see how high they go, that also informs our treatment, because if gases are very high, like say 150, we know exactly about how much on average gas comes down per each treatment type we do. It's about 30 parts per million, 30, 35 for antibiotics and herbal antibiotics on average. There are certainly those cases where you see 70. I've got plenty of those cases, but on average. And then for elemental diet, we know it's more like 70 to 100. So if somebody has a super high gas level, which, by the way, you can't tell by symptom severity, that is very unfortunate. Symptom severity doesn't correlate with gas severity. I'd say 40% of the time it does.
Why do you think that is? If we can take that bunny trail for a second.
I really don't know. I've thought about it. Yeah. I just don't know. I think it's just the great individual variation. What was the terrain like before? What is the terrain like now? What are all their enzymes doing? What's their hydrochloric acid like? What other diseases do they have?
The gut environment is so complex, right?
What's their microbiome? And and then those things, and are they leaning to visceral hypersensitivity or not? Most will have visceral hypersensitivity, but not all. People are just so complex and individual.
Have you seen? I'm sorry. One more question.
No, go ahead.
Have you seen any correlation in symptom severity with, say, the degree of elevation of vinculin antibodies or cytolethal distending toxins?
Let me think about that, because that's a smaller amount of cases that we have those tests for. No, I can't say that I have. No.
Okay.
Right. So back to it, since we can't, sometimes the gas and severity of symptoms do match, but often they don't. So we can't judge by that. So then if we have this gas number, we can see, oh my gosh, you've got 150 parts per million, hydrogen or methane. Why don't we just skip forward, do elemental diet? Because we know we could get 100, we could even get 150 parts per million of gas brought down in 2 weeks. And then we'll save you 6 months of round after round after round, antibiotic or herbal antibiotic. So this is how come I like the test, because it really informs treatment, and it helps us with a prognosis and makes us not be guessing. So those are my thoughts.
Yeah. And I you say herbal antibiotics. I mean, obviously that's a category. There's so many different herbs that fall into that category that have either antibacterial properties specifically, or they're just broadly antimicrobial. So I'm interested in whether or not you see correlations. I did an interview with a doc who works with doctors' data. And a couple of years ago, I think it was, they did an internal study where they looked at microbial sensitivities. They took 1,000 different studies and looked at their antimicrobial sensitivities. And it turned out that, I call it my GUS protocol, grapefruit seed extract, uva ursi, and silver tended to have the most favorable antimicrobial effects on the things that they were culturing and then testing inhibitory sensitivities to. And so, that's one lab. Now it's 1,000 people. That's a decent number to look at, but it's one lab. And I don't know if we asked other labs like Genova or whomever, Diagnostic Solutions, to do the same thing, would we come up with the same answers? So I have two questions when it comes to treatment. One is choosing specific antimicrobial herbs. And the second thing is talking about the distinctions and utility between the elemental diet or specific carbohydrate diet and the low FODMAP diet. Because I listened to one of your interviews not long ago. I think it was Dr. Silverman, might have been. And you had made a comment that the low FODMAP diet was not made for SIBO.
It's true.
And not always effective. And so that fascinates me.
It's about one of our least effective diets for SIBO.
Okay. All right. We got to get there. So let's back up and let's talk.
However, that doesn't really matter. And I can tell you why when we get there.
Okay. Yeah. So let's talk about the antimicrobial herbs, because like when I have conversations, particularly if there are docs that are new to functional medicine, they all want to know what's the best probiotic. That's another question. Do you use them? Do you not?
Oh my gosh.
What's the best antimicrobial herb? What's the best enzyme? What's the best this? And my answer is, I don't know. Like, I think you just have to have a reasonable starting point and then have the mental flexibility to change your plan if what you initially chose isn't working the way that you want to. And I know that frustrates people because we want protocols. Do this exactly like this for X amount of time and everything's going to be fine. And yeah, every once in a while that works out. But I kind of have a rule. I shared this with Datis, Dr. Karazian, once. I like when I teach for him, and a lot of times if I have a lot of new docs in, say, like a blood chemistry analysis course, and they're just starting out, I'll put up Steve's rules for interpreting blood chemistry. And the very last one is, your clients or your patients are under no obligation to follow anything I teach you this weekend. Right? And that's just clinical reality. Is like, we're doing the best that we can, and we base as much as we can on science and maybe even a scientific method, but even then it doesn't always work. Right? So
absolutely. By the way, Datis is who I learned functional medicine from way back.
Yeah, there you go.
So glad to hear you teach from. Love Dr. Karazian.
Absolutely, for sure.
So we actually do have some protocols for SIBO, and this is hard one. It's from doing before and after testing on every treatment we gave at our SIBO specialty center.
Okay.
But one thing I want to say about those herbs you mentioned for doctors' data, I think that is so incredibly helpful that they have that information. But let's just remember that's stool testing, and that's different. They've only just recently added in some of the microorganisms that are overgrown in methane or hydrogen sulfide, SIBO, that can overgrow in the large intestine. Those have just been added in say, the last year or so. They add M. smithii in some of these stool tests. And what's overgrown for hydrogen sulfide? It's Prevotella, Fusobacterium varium. I'm sorry, not Prevotella, Proteus, mirabilis, Fusobacterium varium, and Desulfovibrio piger. And then for methane, it's M. smithii, Methanobrevibacter smithii. But this is just new, and we hardly even know what it means and what are the levels. That's totally not even been figured out.
Right, and then it almost begs the question: like, can you use a stool test to diagnose SIBO?
You cannot.
You cannot.
No, absolutely not. Except now that we know what I just said, that those bacteria can overgrow in the large intestine. Now maybe we can, but that work hasn't been done yet to figure out what are those levels. Stool tests are jumping on board and adding those in. I'm glad that'll help us figure it out, Yeah. Because we used to say absolutely not, the two different organs. And, I used to run stool tests on everybody I did a breath test for. You could see perfect large intestine tests. Amazing I would ever see any of those, but I would with the rampant SIBO. So, and because you'd imagine there'd be spillover, right? But no, not necessarily. Okay, so back to it. Yeah, there are distinct things that seem to work we know the exact bacteria that are overgrown now. That's been years of work. And we only just have those final hydrogen sulfide ones that came out 1 year ago with studies. So that's been the real thrust of work in the last few years, is which exact bacteria, methanogens are overgrown in these different types of SIBO. Now we have that information. Now we can really figure out what treatments are going to work. However, clinically, we've been figuring it out for years, right? So what we know is what works for hydrogen is oregano, neem, and berberine. And berberine is a constituent in many herbs. So, golden seal, Oregon grape, coptis, philodendron, etc. We know that what works for... So here's where we get into trouble is those same things don't necessarily work for methane. These are not bacteria. They're archaea. Different things work on them. We know different antibiotics work in different, infections. I've seen it all the time. People take an antibiotic. It doesn't work. You have to switch to a different one. You've got to get the right thing for the right bug you're trying to target. I hate to think so like that, but this is the truth of it, So for methane, we know that allicin works, the constituent from garlic. We don't like to use whole garlic, aged garlic oil, because it can trigger symptoms, because garlic is very high fermentable. So we really try to use the purified allicin. So we use Alimed, or Alimax Pro is the one we tend to use. And that's the one we did all our testing on. I mean, others may work. I'm sure they would, but that's the one we did the testing on. And when we tried products that were like whole garlic, we just ran into so much aggravation of symptoms. And then also Atrantil. That is a little 3-herb combo that's been tested and shown to reduce methane. And it works differently. It's not so much a straight-on killer. So it's got peppermint, red quebracho bark, and conker tree, which is horse chestnut. And what this is doing is actually making it so the methanogens are not being able to produce methane gas. It's not so much killing them. They just are not able to make the gas. And it's the gas that causes the slowing causes the constipation.
So do you have to, just right from a clinical perspective, do you have to use Atrantil with something like, what did you say kills the allicin, the highly purified allicin? Do you have to use those together?
No, you don't. So you choose one or the other. So what we typically do I call this the single herb approach. It's not really single, but as opposed to just grabbing a big formula off the shelf that has 25 things in it. Because that's another way to go, and we can talk about that. But you choose something for hydrogen, because there's always hydrogen there. The reason why, even if you don't see it on a test, is because methane is made from hydrogen. So there are always the bacteria there that are making the hydrogen, but then the methanogens are turning that hydrogen into methane. Sorry to get so technical, but this is
exactly what I'm looking for.
So even if you only see methane on a test, you always have to treat hydrogen at the same time. That's the way we do it. So you choose one of the hydrogen herbs. And if we were talking pharmaceutical antibiotics, it'd be the same. You choose one of the hydrogen pharmaceutical antibiotics, and then you add the herb or antibiotic that treats methane. So then you choose either allicin or Atrantil. And so in the case where there's methane, you're always doing 2. We always do 2 for hydrogen also. By the way, let's just take this on. Why don't we just add more and more and more? because it doesn't increase efficacy. We've tested it. And so more does not equal bigger reduction in gas. You peter out at about three herbs. Now, with the exception of something like Atrantil, that's a small little formula, that has 3 herbs. And so we'll use that with a hydrogen herb. And then for hydrogen sulfide, what we know works is bismuth, which is not actually an herb. It's like a mineral. And high-dose oregano. And high-dose oregano is something that came to us from a patient years and years ago, which was originally an old chiropractic blastocystis hominis treatment. It came from the chiropractic world, and it's very high dose. But
when you say high dose, what do you mean?
So typically we're using ADP. That's like the dry oregano. We're not using the liquid oil of oregano.
Biotics, isn't it?
Yes,
Biotics
and the reason we did that is because that came from Dr. Jerry Mullen from Johns Hopkins. He had been using that. He teaches for the Functional Medicine Institute. He had been using it with success, so we began using it. And what we found was that dry form was better tolerated, actually, than the oil form. Oregano can be pretty caustic on mucous membranes, and even the dry form, but the dry form is better tolerated. So we're talking 5 pills 3 times a day for the first week. That's 15 pills a day. And then 9 pills a day, 3 pills 3 times a day for the next 3 weeks to make a month treatment. That's something we haven't mentioned. Herbs, the typical herbal treatment round is 4 weeks, can extend to 6 weeks. Whereas for elemental diet and pharmaceutical antibiotics, it's 2 weeks. So they have the same effectiveness, but herbs just take a little longer. So you just have to use them a little
is that 6-week cycle, is that, in your opinion, unique to SIBO, or would you include any large intestine dysbiotic case to be the same rules?
I don't know, because I don't treat.
Because you only do SIBO.
Of course I have treated some LIBO, but I wouldn't want to pin my, I'd want to ask someone who does run stool tests and treat that regularly.
Well, can I share something with you? Because this is like when I first started, and I learned functional medicine from Dr. Karazin as well. And I've been doing it. Well, I've been teaching for him since 2008. So sometime before that, I started learning. But
2008, did you say?
Yeah, teaching for Apex and Datis since.
Oh, that's so long. I love it. Yeah,
That's feel like I blinked, and it's 2025.
That's amazing. Yeah, I think I first started studying with him in 2006, I think.
Yeah, and so we probably got involved with him somewhere around the same time, probably in different parts of the country. I was in Florida at the time, but in the and this is before Datis and the company he formulates were called Apex Energetics, before they started to increase the number of formulas that Datis had brought to the market. And so I was using predominantly Genova's GI effects test, and I was using, and it's my own podcast, I could mention anything I want. I was using Apex's HPLR and the product called Mycozyme. I was using those 2 things in combination. And I would probably do 2 capsules 2 times a day of each of those. And I would run a 12-week protocol, and I would retest the stool in 9 weeks. And 90%-ish of the time, the second stool test was either perfectly normal or very close to it. Every once in a while, you'd see that wacky second test that looked worse than the first one. And it confused me for such a very long time until I started reading about biofilm. Right? And so I want to bring that to the SIBO discussion. Do we have to account for biofilm with SIBO? If the answer is no, we can move on. But if the answer is yes, can we talk about biofilm and maybe talk about the strategies that you're using for biofilm disruption?
Yeah. So this is very interesting to me. I think we're still figuring this out. Early on, we made an assumption when we were treating. 90% or more of relapsing infection type diseases are biofilm diseases. So could this be part of the reason why we're seeing so much relapse, right? There's biofilm and we didn't get it. And so the infection can just come back. So on that assumption, we gave many of our patients antibiofilms. We worked real hard at it, and we used the enzymes, we used EDTA, and we used that's mostly it. The ceratopeptidase, that was also an enzyme, like lipophos EDTA and all the classic ones, right? And NAC. We used NAC because NAC is excellent antibiofilm for H. pylori.
Yep.
really good studies on that. So we used all of those hardcore, not on everybody. So we had samples to see back and forth. This isn't a formal study, but this is just clinically. I'd say for about two or more years, maybe like 3 years. And it seemed to make no difference at all. And we were very disappointed. Okay, so then fast forward, I have a conversation with Dr. Paul Anderson, who's an elder in the naturopathic profession, treats very difficult cases, a lot of biofilm infections. And he said, well, that's because the antibiofilms you were using are not good enough. Mm-hmm. And you really need to use a bismuth-based, a bismuthiol-based antibiofilm. And at the time, he had this compounded formula, it's prescription, that he had developed. And not even every compounding pharmacy could make it. And you had to get it special from certain places. Now more can make it. So I started using it. That made a difference. That made a difference. That helped. That moved the needle on some really tough cases. Then, this was quite a long time ago, then he came out with an over-the-counter version of it. And that is Priority 1 Biofilm Phase 2 Advanced.
I use that all the time.
And I may have those, sometimes I say those words wrong because it's a lot of words. Yeah. Which one comes? Yeah. Does advanced come first? I don't know. But I can definitely say it's not as strong as I've used it so much. And it's not as strong as the compounded. Sometimes that's good, right? Yeah, but sure. I think the compounded is more effective. So, okay, so there's that piece. What I would say is and also I want to say that, so there were a lot of people we didn't treat with antibiofilm that got completely better. And yes, like the classic scenario in SIBO is it's not cleared with one round. There are one and dones, but that is a smaller proportion, particularly in a specialty practice. Most people will need multiple rounds, but even still with multiple rounds, no antibiofilm, they got all better. So clearly not everybody does biofilms need to be addressed in SIBO. But if you're really having trouble, that's when I would think of it. Okay, so we have this. Then we have something additional to add. Just last year, out came a study from Dr. Pimentel and team using a special formulation of NAC with rifaximin. Now, from my understanding, it's complexed with the rifaximin, and there's a time release situation going on there. And that greatly increased the efficacy of the success of the rifaximin. Rifaximin, for anyone listening, is our main antibiotic we use for hydrogen SIBO. It's also called Xifaxan. So this was, at first, when I heard this, I didn't hear the special formulation part. And I was like, what are you talking about? We used NAC for years with zero benefit. I'm like, I am having a hard time believing this. Then I heard about the special formulation because we were just using, immediately absorbed NAC. And so what Dr. Pimentel has said is you really have to get it down into the small intestine, hence the special time release situation there, or sustained. There is a sustained release by Jaro. So if anyone is going to try this with any of their SIBO treatments, I'd at least recommend that until whatever because they're developing a product. So until that comes out. So that's more to add to the biofilm piece. So apparently, Dr. Pimentel has talked about how methanogens and certain of these overgrown bacteria are living in biofilms. He's been able to see that with his endoscopy, the scope going down and the sampling. So I think that could be important. So maybe we should all be adding sustained release NAC to our treatments.
I was teaching a course in it was West Palm Beach many years ago. And it was around the time where we as a group in the Apex ecosystem were starting to teach on biofilm. And I remember a young guy coming up on a break, and he told me that his uncle, if I remember the story, his uncle was a biofilm researcher at one of the universities in Israel. And I asked him immediately, like, what is he seeing is working? And he said the two things that they're seeing is working is cranberry extract and stevia.
Wow.
Yeah. And I know that a lot of people
that's a great tip. Thank you.
Yeah. Real a lot of the docs that are Lyme literate rely a lot on both either stevia or cranberry as their primary biofilm strategy. Now, I wonder, like you hear stuff like that, and that's great. You hear stuff about bismuth, and that's great. And then I wonder about individual variability. Like, do we have to account for that? Is cranberry going to bust all biofilm in all places in all people? Right? Or do we have to have a stable of things to choose from, and then we mix and match depending on their response. And that brings me to the next question. You mentioned some people need multiple rounds, and a round, I guess, roughly is 6 weeks long.
I'd say 4 weeks.
Okay, 4 weeks
is a typical round. We stretch it to 6 if they have higher gas.
Okay. And then how long in between each round? Is it only when a relapse happen, or is this pre-planned? You're going to do 4 weeks, take X amount of time off, do a second round. And if that's the case, or either way, do you change the protocol each time?
Oh, these are such good questions. Okay. So it brings up sort of an underneath question was, why not just go longer? Why stop?
Yep.
Why, right? Believe me, we tried it. And what we found over and over, now, once again, this is in the patient population that we were seeing, which is at a specialty center. So it may not be the same for the first, for primary care or something.
Yep.
But we just found that the treatment lost efficacy somewhere around 5 or 6 weeks. And so what would happen is somebody might have had some improvement in their symptoms, and they would just begin relapsing while still on it. While still on it. So this happened so often. And so this is how we learn, right? And so that's why 4 weeks, you really have a potent treatment. Even at 5 weeks, we could start seeing some people. Now, people are going to say, they're going to know, they're going to have experienced exceptions to this rule. I will tell you, I have experienced exceptions to this. I've certainly seen people that have been on the same thing for 2 years. It's working, and they come to me to help me get them off of it. It's the only thing that works, and they don't want to be taking it every day. Of course, there are exceptions.
Sure.
I'm just talking about patterns, right? So what we do is, now this is again, if you have testing and people have to figure out their own way that this is going to work for them. But typically after a round, we need to see how the patient is off of the treatment, because the treatment could be giving them symptoms or die off or whatever. We have to see, how are they? We have to assess, are they better? We're looking for 90% better. So we need a little time to see what that's like. If they are not better, that's when typically we will do a retest and find out what's happened. A lot of times the gases have changed, things, it helps, again, inform our treatment. But the key thing is, you don't want to wait more than about 2 weeks. And why is this? Before you start your next treatment, if they're still positive. And you can do this without testing. We can talk about that. But why that is because relapse, or really here, we'll call it backsliding, is so common at about 2 weeks. It's just classic. And so
that's 2 weeks after stopping a 4-week round?
Yep. Or if it was antibiotics or elemental diet, the 2-week round. And it's because we don't want to lose ground. So what we do in this 2-week period is we put someone on a prokinetic. Prokinetics we haven't talked about yet. An absolute essential part of SIBO treatment that gets missed often. You want a moment or two without them on the prokinetic too, like a day or something if you can, because what if they start to have some sort of reaction to that? You need to see, how are you? Then get them on the prokinetic while you're waiting for the test to come back or figuring out what you're going to do. But if you wait more than 2 weeks, if they're not clear of their SIBO, that overgrowth can really start to come back and you lose ground of what you just did.
Yeah.
So if you don't have a test, let's say you have an initial test and you saw they were, at 70, you can calculate, well, with herbs, it's about 30 parts per million. And by the way, that information is gold, comes from just cajillions of before and after tests. And it's just an average. Okay, so one round we'll expect, 70 minus 30, they're still positive. We kind of suspect they're going to need another round. So see how they are after one round, because what if it did it? And, if they're still symptomatic, maybe you don't go for that next retest due to budget and time and logistics. And then you have in mind what your next round is going to be. So to your next question, I always typically switch because we're concerned about clinical resistance or clinical tolerance to what we're giving, because we see it so commonly. We see that happening even to rifaximin, which has been studied and shown to have 7 repeat rounds with no antibacterial resistance. Yet we saw it. We saw it a lot. So we'll switch. Now, you don't have to switch. Let's say somebody was really doing great. They weren't having any backsliding at all. You take a 2-week break or a week and a half break just so you can assess or whatever. You can use the same thing again if you really think it was working. And if you got some feedback from the patient, yeah, we do that. But the typical thing is to switch and, switch around, which is then where we start to run out of, well, what are all of our options that treat each thing,
Yeah.
And then just one other thing to just mention here, just briefly, we didn't talk about like big formulas, because there have been some formulas studied for SIBO. Canibactin AR/BR and FC-Cidal and FC-Cidal and dysbiocide. Those were studied for SIBO and shown to be efficacious. Really, these are going to work for hydrogen. They don't really have anything in it much for methane, although oregano sometimes works for methane, and that is in those. It's not as reliable, though, on a day in, day out basis. The issue for me with these big formulas is that I think they're great for primary care when you're not even sure, am I dealing with SIBO? Could there be LIBO? Is there yeast? We didn't really talk about that. It throws a big net, and that is great and I think appropriate. But when you're really trying to dial it in and you're really just trying to treat the SIBO, you do need to get a bit more specific, I find. If so long as, maybe that took care of it. I just mean if you are now continuing to struggle with a SIBO, then you need to dial it in and get specific with those organisms that are overgrown. And the other thing is the clinical resistance. We know so many people are going to need multiple rounds, just as a matter of course. Most people need 2 to 5 treatment rounds. And we don't want them if we have everything in one, what will we use for our next round if they become resistant? Sure. So we're just being practical. And lastly is we see so many sensitive patients, and they have histamine intolerance, they have mold, MCAS, all these things, and they have a very hard time with various herbs. Using a lot of herbs at once, how can we figure out what was bothering them if there's 25 things in there? If we're using 2 things, we can take one away and then we can easily figure it out. So this is just clinical practicality.
Yeah. So would it be a workable framework to perhaps anticipate, whether you actually do it or not, but anticipate multiple rounds, 4 weeks each, maximum of 2 weeks in between each round, especially dependent on either return of symptoms or if you post-test the results.
Right. Exactly.
And maybe up to 4 or 5 4-week rounds.
Yes, that can happen. It's common, actually. Yeah.
Yeah.
Yeah. That's one thing people give up too soon. They're like, well, I took a round of something, and we see it in the medical world all the time. And I think you alluded to that. They threw rifaximin at someone, or I took a round of something. I'm not better. I must have a tough case or I'll never get rid of it. It's like, no, you just started.
Or the doctor's incompetent, right? That's the other option, is blame the doctor.
Or I must not really have SIBO if there wasn't a test. It's like, what? It's like, what? You just did your first round. See, if you don't know, it's like, no, you're just getting going.
I know that you've operated as that specialist and typically with failed cases, but if you were in a situation where you were routinely the first doctor seeing someone for complaints, would you still do a breath test, or would you rely more on dietary tolerance and changes, maybe put them on either a few days of a low FODMAP diet, we'll come back to that, or an elemental diet? And if so,
an elemental diet, that is different. That is an actual antibacterial treatment. So that's like an antibiotic in essence.
Okay, so why don't we switch? Are you okay with time? Can we?
Yes.
Okay, that's great. Because I'm not done yet.
Okay.
So let's talk about the dietary approaches, because even in the Apex ecosystem, we've taught a 1-day seminar on small intestinal bacterial overgrowth, right? This is something that Datis developed back probably 2014 or something like that.
Yeah, I think it was right around the time he and I were having a lot of conversations.
Yeah, and I think
he has an extremely different approach and thinking on SIBO than
and
us.
this is why I want to broach this subject, because, and maybe what I've been calling SIBO is not SIBO, because I've been using a low FODMAP diet. Now, each iteration of that diet is highly patient specific. And as you know, there's a bajillion different SIBO low FODMAP diet lists out there, right? Everyone seems to have their own list, and I'm interested in this because you were talking about using Allison and how garlic in various forms is typically not tolerated very well. Let's go back to context. And maybe this is a hypothetical you can't or don't really want to answer, and that's okay. But if you were the first line doc, would you tend to rely on a dietary challenge, remove certain foods, see what that does, and then make decisions based on that? Or would you still be doing, say, a Trio Smart test, even though it's the first line and you're not a complicated case that's failed a bunch of other things?
Personally, I would test, and I wouldn't use diet. This is just me. I don't want to you have a method that works for you. So I don't, it's like, why?
Well, listen, I'm always looking, I'm always looking to be a better clinician. So if it works, great, but I want it to work better.
So I would test because we know that the differential diagnosis for SIBO is 35 to 40 diseases big. Those same symptoms can be caused by so very many things. And dietarily, I feel it's similar. It's like we're not going to have specificity knowing it's SIBO without that actual test. So if I actually want to figure out if it's SIBO, then personally, I would test, especially because the breath test, it's that problem of the differential diagnosis. And also because, like just for example, the classic example is lactose intolerance, which can be genetic, but could also be secondary to something else like SIBO, right? But let's say they have genetic lactose intolerance. Studies have shown many people who have it honestly don't know it. They don't know that it's milk or dairy products giving them their symptoms for their whole life. It's like amazing. There's studies showing that. And because, it's an education issue, and you give them a FODMAP diet that they remove lactose, they respond. So then you think they have SIBO, but in fact, the solution is to avoid lactose or bring in an enzyme. And why are we now giving them antibacterials and messing with their microbiome? So it's this differential diagnosis list that it causes a problem for us, but we do have a solution, which is the test.
Yeah.
So that is the reason I would do it, just to be sure. Especially, I personally feel like I'm ever going to use an antibacterial of any kind, I want to be sure that it is the right thing for the problem. So that's why I like the test. And then additionally, because we get so much nuanced information, the gas types and the severity, prognosis, treatment type, etc. It really helps.
Yeah. Right. So let's talk about the diets that we've listed. For anyone listening who doesn't know what a FODMAP diet, it's FODMAP. It's fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And these are fermentable compounds in certain foods. They're higher in certain foods than others, mostly fruits and vegetables, certain starches and grains. And the theory that I've been operating under, and again, this is how I was taught, I didn't question it, was that certain people need to go on a low FODMAP diet because eating those foods feeds the little critters in the small intestine that shouldn't be there anyways. And then they produce hydrogen, methane, certain gases that cause bloating, distension. Now, you're saying that the FODMAP diet was never intended for SIBO. So what was it? Like, if you know, what was the original intent for the FODMAP diet?
Well, originally it was like Crohn's in the small intestine, so IBD, and IBS of the large intestine. They did actually mention SIBO in some of their early papers, but it was not created for SIBO. It was created for IBS with the mindset of the large intestine.
Interesting.
The issue where we run into the problems with FODMAP is that they are not removing fiber. Of course, fiber has a lot of definitions. Well, I'm going to call it long chain fiber. What we think of as fiber, like supplemental fiber and like flaxseed and things like that. And in fact, they encourage increasing it. They want to be sure you don't go too low fiber. And fiber is direct food for the overgrown bacteria and directly will contribute to symptoms. Right. So this is why I say who cares what it was originally developed for? I don't care. This diet, yes, it's true. If you do it just as written, I would say it's one of our least effective compared to the other main diets we have for SIBO. But that doesn't matter because you can start with any of these reduced carbohydrate diets, any of them at all, even ones that are just for weight loss, and just start tweaking it to the individual, which you already indicated you do all the time anyway.
Right.
And so it doesn't matter what diet you start with, because whatever diet you start with, I think that's a key thing to understand, is to know that no diet that is used for SIBO will be right for each person, and that it's really encouraged to experiment, because there are usually always things on that diet that you will have no problem eating and that they say you shouldn't be eating. And you should test that because you want to include as many foods, and vice versa. There'll be things on the diet that you're reacting to that you need to remove. And I think where that mindset comes in is with SCD, specific carbohydrate diet, because that was also created for inflammatory bowel disease. well, actually, sorry, it was created for celiac. They think it's for celiac, but really we really think it's inflammatory bowel disease that originally Dr. Haas was treating. I know that gets way back into history, but that diet has this idea of fanatical adherence. They have it right in their book, fanatical adherence, and that you can't go off it even one tiny bit. And so that is not an appropriate attitude with SIBO. So if for anyone who's been indoctrinated through there, know that we want you to experiment with your diet in SIBO. So yeah.
And so is there a distinction between the SCD diet and an elemental diet? And which one are you using as your starting point for most of your clients?
Yeah, so elemental diet is not a diet in the way we think of specific carbohydrate diet, FODMAP diet, any of these other diet. Like it's not a food diet. It's an antibacterial treatment, but in a slightly different way. So what it is it's a medical food beverage that's a powder of nutrients in their most broken down form. So it's amino acids for protein. It is oil for fat. And then the carbohydrates are either glucose or maltodextrin, this more broken down. And then there's vitamins, minerals, and salt. And it used to just be like, you'd have things like Vivinex. Vivinex Plus is the one that was studied for SIBO originally. And then there were things like Neocate Jr., and these are used in hospitals to give the digestion a rest. So for a long time, I actually didn't even use the word diet. I changed it to elemental formula because people were getting confused thinking it was a diet. It's not a diet. It's a special treatment. So how we do it for SIBO is the protocol developed by Dr. Pimentel is you take this drink and no other food. So you're not eating any solids. You're not drinking just anything but water and this for 2 weeks. So it's kind of like a form of fasting. And what you're doing is starving the bacteria, starving the methanogens or bacteria while still feeding the patient or the person, because those nutrients are absorbing so quickly across the top of the small intestine, they're getting into the body before the bacteria have a chance to consume them. So it's a different method of killing. Antibiotics and herbal antibiotics are our typical sort of, hurt the cell wall, DNA replication. This is just starving the bacteria. And what Dr. Pimentel has found is it takes about 10 days to really get the appropriate killing because the bacteria can eat our mucus. They can eat various aspects of our intestine. So you need a good 10 days, but 14 days is 2 weeks is the typical round. Sometimes we go to a third week. So that's kind of like how sometimes we go to 6 weeks of herbs. Sometimes we go to a third week. If a person's willing and needed, we usually do a retest to find out. So where this comes in is it's when you are deciding how you're going to attack the bacteria overgrowth itself with killing agents. You're going to choose either pharmaceutical antibiotics, herbal antibiotics, or elemental diet. We have these 3 choices. And for myself personally, I decided to practice in a way where I was using all 3 equally. I would offer them all 3 to my patients, and together we would make the decision of what we were going to do. Except for the fact that when someone is very high gas level, as I explained, elemental diet has this amazing ability to reduce gas, 100 parts per million in 2 weeks.
Yeah, well, so you're taking away the fuel supply.
Yeah. So it's really, in that way, it's more effective, but it's, just because it can reduce more gas in a shorter amount of time.
Right.
But then again, sometimes it just doesn't work at all, just like with everything we use for every problem we ever treat. Right? So nothing is guaranteed. And believe me, when you treat enough things, you will see your morning patient dropped amazing. They're all better. The second patient, same treatment, didn't do a darn thing. This is just what happens, Now, so then diet, as to your question, which diet do we use first? I myself used about 4 different diets with regularity. I used SCD. I used low FODMAP. I did use GAPS in the beginning quite a bit, but we dropped that. We found that wasn't quite as good of a match. And then I created my own version of combining, because SCD and FODMAP are opposite in some of the things that they eliminate. So I combined them together. So that's called I just gave it the name SIBO Specific Food Guide. I used to call it SIBO Specific Diet, but I prefer Food Guide just because it's more like, So that's my version of those 2 together. Then my friend, Dr. Jacoby, took that diet, my diet, the SIBO specific food guide, and just put it into phases. And she calls her the SIBO biphasic diet. It's the same. They're the same diet. Hers just is in phases. And hers is much more structured. It's better for people who want more structure.
Yep.
Whereas the food guide is really almost like a shopping guide,
Gotcha.
So I was using my SIBO specific food guide, FODMAP, SCD, and GAPS. And there was one, and then the other one is the Cedar Sinai diet. This is developed by Dr. Pimentel. And he now has renamed it and sort of made it a lot more comprehensive. And it's called the good life eating or something like that. I forgot the new name. But it's on my free website.
Able to find it. Right.
I've changed the name on my website. I just don't have it memorized yet. Good life, I think it is. Low fermentation eating. That's it. LFE. Good LFE diet. Okay. Got it. So yes. So honestly, I chose between those diets for each and every patient. There wasn't one I always went to. Now, in my larger community, because so many people knew me and honestly, what we found is that the SIBO specific food guide, it is the most restricted out of all the diets. It's the combination of 2 diets. It therefore, honestly, works the best in terms of reducing the most symptoms, simply because it's removing the most carbohydrates. But I don't always go to that first. But many people in my larger community would use that first. That's the same as SIBO biphasic diet, because they could get the best symptom results. But I don't think that's always the way to go. And I would customize my choice to each person. I understand that's not practical for a lot of people. This is my entire specialty. I'm in and out, back and forth, familiar with every one of these diets. I could immediately see which one was going to be right for each person based on their lifestyle and various factors from using them all for years. So that's why I say it doesn't matter which one you use. Choose whichever one you think has the prettiest cover design. Who cares? Just start with something, but the key is get them to tweak and experiment. Now, here's the other side. Do you even need to do all that experimentation and tweaking? And how much do you even need to use diet if you can just get right in there with killing agents, get rid of the bacteria? The whole point of having all these food issues, what does the diet really help with? It helps with symptoms. And what are the symptoms from? The overgrowth. If you could just get rid of the overgrowth, do you even need to do a diet? So, Pimentel just waits and brings the diet in after the fact as a sort of help in preventative measure. And his Cedar Sinai diet, low fermentation eating, is a more expanded diet and very good for the prevention phase. But honestly, even still, his diet is probably better at symptomatic reduction as written than low FODMAP. But I don't mean to say, I mean, of course, I had people with low FODMAP who got 100% symptom relief, but there was a few, Yeah. And you just have to tweak it, Yeah.
So I have a ton of questions. Going back to the elemental drink. So that's the only food that they're consuming, right? So it's like you said, it's a fast. Do you, off the top of your head, do you know with whatever drink you're using, do you know what the calories levels are? Do you know what the protein intake is off the top of your head?
Yeah, they want you to, the recommendation is 1,800 calories a day. Some people may need 2,000. Okay. You can also calculate that for the individual. The protein, I don't remember off the top of my head. The standard elemental diet formulas are higher in carbs. And what we found a problem with way back when I first started treating SIBO, there was only Vivinex Plus and like Neocate Jr. on the market. And Vivinex Plus was very expensive. These aren't covered by insurance. They're over the counter. And my patients couldn't afford it. And so I created recipes, homemade recipes. Took me quite a long time to figure out. I was really trying to exactly match Vivinex Plus because that is the one that was studied and shown to work. Took me a long time, but I have those free on my website, those recipes. And one of the key things there is I have a low carb version because so many people do not want that high of a carbohydrate that comes in those elemental diets.
Yeah. I mean, and I'm wondering because these people who do have SIBO or things that might masquerade as SIBO, they usually have other metabolic challenges, right? They might have reactive hypoglycemia, for example.
Oh, God,
yeah. So do you find if you put somebody with SIBO on this elemental approach, do you see their blood sugar destabilizing or do you actually see it getting better? You see it destabilizing? Yeah.
Because it's hard. There's a big bolus of carbohydrates, and some of we often see a lot of like die-off symptoms and reactions because more things could be dying too than you know of. But we think a lot of the sort of die-off and symptoms we're seeing is reactive hypoglycemia, and so the recommendation is not to drink it as bam, slam it down in three distinct meals, but sip it over time.
Throughout the day.
Over maybe an hour or something instead of just because it's just too much.
For sure. Yeah. So is it your general approach? I want to make sure I'm tracking with you as we're talking through all these different variables. It doesn't sound like you start or finish the same way with every person, which I like, right? Everyone's different. But if you were to say, when I look at all the ways that I approach these problems, this is the most common way that I do it. Would that be a couple of weeks of this elemental drink and no food, and then merging into some dietary choice? And you might have 3 or 4 different options, and you try to match the diet to the individual. And it's not just about what you think they will or won't react to, it's what they can adhere to. Some people need more structure. Some people just like it's more of a DIY. Like, here's your guidelines. Go ahead and, go.
Some people bristle against structure. They don't tell me what to do. And so, here's just this simple. And some people are like, I will never stop drinking Diet Coke. I'm like, okay, I know which diet to give you. It's like, I mean, not that they can't have the Diet Coke on whatever diet they want, but I'm just saying to start with, it's like, okay.
Yeah, just recently I've been getting emails. I probably should have looked at it before you and I jumped on, but I'm getting emails from a couple of different companies I've never heard of that are, like, we've got this elemental approach for SIBO, and now companies are creating products to address some of these challenges.
Oh, we have a whole slew of wonderful commercial elemental diets on the market now. In fact, I was involved with, I begged various companies to make cleaner versions of elemental diets, and I was involved in advising the first one who made it. Was Physicians Elemental Diet, who made it way back when. But now we actually have a phenomenal new one on the market. Came out a year ago. Dr. Pimentel was involved in creating this one. It's called M-Biota Elemental Diet, and the reason I'm mentioning it is because palatability is a significant challenge and issue in all of these elemental diets. Yeah. These companies try so hard to get them to be very palatable. This is way above all. I'm sorry, all the other ones in palatability. I'm sorry, other brands. I love you too, but
it happens.
It needs to be mentioned that this one tastes better. So there you go.
Yeah. So when you go and trying to fold this back into things we were talking about earlier, if we think about 4-week iterations, and that's usually you have to do more than one 4-week course, are you proceeding each 4-week with a 2-week elemental approach? Or
no, because 4-week is just for herbs. So remember, we're choosing between 2 weeks of pharmaceuticals or 2 weeks of elemental or 4 weeks of herbal. Those are our 3 choices, and we're choosing one of those as our killing strategies for our first round.
Gotcha.
And then we're assessing, of course, get them on the prokinetic, and then assess. And then if they need more treatment rounds, we are once again choosing between pharmaceutical for 2 rounds, herbal for 4 not rounds, weeks, herbal for 4 weeks, or elemental for 2 weeks. We come back to those choices each and every time.
Yeah.
Yeah. I, as a specialist, couldn't treat SIBO with just herbs. That I would lose my job. I have to have more tools than that. Yeah. I couldn't do it.
If you really had to choose, if somebody somehow had the power over you to say, you can either only treat SIBO clients with diet or for nutraceuticals, and you can't use both, which one would you choose?
Now, do you mean between antibiotics, herbal antibiotics, and elemental diet, or do you mean like diet?
Well, no. Let's include those 3. So someone proverbially puts a gun to your head and says you can only use one tool: pharmaceuticals, nutraceuticals, or diet.
And nutraceuticals, you mean herbal antibiotics, right?
Yes, I'm sorry.
Yeah.
Herbal.
Okay.
Yes.
Okay. It's extremely difficult because the reason being is due to sensitivity of patients. Because as a specialist, I see so many highly sensitive patients, meaning, which I think many people know what I mean, but they react easily to supplements, medicines, and foods. People like that do best with pharmaceuticals. Absolutely, without a doubt. If I was to but I don't want to put everybody on a pharmaceutical antibiotic. Right. So therefore, let's put that aside. Let's pretend I don't have a huge amount of sensitive patients I have to deal with.
Okay.
Then I would probably choose elemental diet because it can bring the super high gas level down. But then not everybody wants to do that. In fact, most everybody will come to that last because it's like fasting. It's difficult. It's challenging.
Yeah, people don't want to do it. Yeah.
Yeah, they don't want to do it. But what, I always say this, what people always say, like we do all these rounds of all these herbs, all these other things. And then finally we need to come to elemental because they're become clinically tolerant to all these other things. And then they go, oh my God, I just wish I'd done this first. And that's why I would choose that one because of so many.
Yeah, that feedback from your clients is very important.
But they also say this, but I wasn't ready to.
I wasn't ready, yeah.
They had to go through all that to be, okay, I'll do and then they do, oh, why didn't I just do this at first? Bam, it's gone, all the super high gas level gone, but it's difficult. So, but that's the one I would choose.
Is your goal in treatment to get the follow-up breath tests down to perfect baseline, or do you look for a combination of good quality of life, control of symptoms, lack of flare-ups, and close enough to call it good?
My goal is 90% better in symptoms, and that's subjective. That's judged by the patient and myself together, figuring that out. And I don't retest if somebody is 90% better in symptoms.
And they don't relapse within that 2-week window or 3-month window?
Most classic time for relapse is actually at about 2.5 to 3 months post eradication of SIBO. But some people, it's a year. That they're not going to relapse for a year. So, of course, we don't want to see them relapse. But my treatment goal for like the killing agents is 90% better in symptoms. And because if they're 80% better, many gastroenterologists shoot for 80%. And what I found is if we really kind of decide they're 80% better, if I do one more treatment round, we can usually get them to 90%. So that's why I like 90%. I mean, some people get 100%, but we're shooting for 90. 90 is darn good.
Yeah.
And
for sure.
and so and then that's my goal. And then in terms of like are they going to relapse or not? We're going to see. And if they relapse, that's what I'm going to focus on figuring out underlying cause. What if they never relapse? I don't need to really think about that unless they're going to relapse, right? And what's their diet like after? We'll manage that as it goes and take it from there.
Have you developed any predictors of relapse? Things that you look for that increase the probability or at least your expectation?
Well, I've been able to identify one thing that predicts not a relapse. This is when it's an interesting pattern. It's when somebody does the treatment, whatever treatment, and afterwards maybe they're 80% better, but I don't always move to another round when they're 80% better. Because obviously I had to figure it out first that I wanted to do that. And then over the next month, they get like 100% better. Those people do very well.
Mm.
The people that are like, maybe they're not at a perfect right after the treatment. I think what's going on is they're healing. Because there's physical damage that occurs to the lining of the intestines. Enzymes are removed. Lactase enzyme is removed. Leaky gut is caused in many people, etc. And I think now that the bacteria is gone, it takes a couple weeks for, we know, like after, about a food poisoning, some people can have temporary lactose intolerance. It heals in about 2 weeks. So in about 2 weeks, I think, they're starting to get better and better. And then they even improve a little. So then we don't repeat. And then, of course, you have to be in communication with them about this. Sure. And then they just even get better after that. And so then after about a month, they're golden. Those people. So
that's like a critical window.
Yeah, that's true.
Yeah. All right, we're right at 2 hours. So let me.
I know.
Well, this is great. This is exactly the kind of.
And we never even talked about prokinetics, so we don't have to talk about it. But people, you have to know how important.
No, let's do it. And I do. I kind of want to end on one. So let's talk about prokinetics, and we can go. I'm not restricted on time. But I would like to ask you maybe as the last segment after the prokinetics is to ask when you're dealing with difficult cases, how often do you have to go outside of what you're doing for SIBO to look for reasons why people are not responding? Whether it's
all the time.
Okay.
100%.
Okay, so let's deal with that now. And we'll get to the prokinetic. So do you have a short list of let's say the usual suspects?
Of that?
Yeah.
Mold. Top.
Mold is the
number one. Number one.
So my big question on the mold is, you're talking about like Stachybotrys. You're talking about black mold, toxic mold, or are you talking about the foodborne mycotoxins that make up most of the analytes on urinary mold testing?
Mycotoxins as well as mold.
Both. So just in general.
Yep. Yes, that's right. And I'm not an expert in this, but all I know is that mold illness, including mycotoxins, it causes very difficult cases of SIBO. And it's the first place we want to look when we have a tough case. Now, how do we even define a tough case? That we should discuss, but we can leave that for another time, because I just want to say, it's, as we mentioned before, it's not doing a few rounds and it not working. It's not that. Like the classic thing with mold, when you want to think about mold, the pattern is a person improves somewhat, very temporarily, after every treatment you give. I mean, it's like, they're improved maybe during a little bit or for a few days afterwards and immediately back. You cannot make headway. There's something preventing you from making headway. So other things that could be like that would be parasites. We've seen that. Sometimes H. pylori, which almost could be considered like a parasite. It's not, but just in terms of like a chronic sort of infection. And all those other causes that we talked about, those underlying conditions, those need to be, managed. Those need to be looked at and managed when you have a very tough case. But, tough cases are, very difficult relapsing, not being able to move forward. There's a lot of ways we can define tough cases, but it's, basic. Another thing is not responding to all these treatments I mentioned that we know work, not responding at all to them. What's going on there?
Obviously there's a block. Yeah.
Yeah, right. So those sorts of things. But basically, yes, we're going to look at all the underlying causes and associated diseases, particularly underlying causes. And MCAS and histamine is a huge issue in difficult cases because it prevents people from taking the treatments we need to give them. It limits their diet much, much further, and they're just sensitive to everything. It's very difficult. And of course, mold can cause that.
What kind of diagnostics are you running in a case where you suspect mold?
I'm referring.
You are? Okay.
Yeah, I refer to a mold literate practitioner.
Okay.
Yeah.
What?
And
so let me come in through the side door and ask, what kind of testing are you seeing them do?
Well, I know that they check for mycotoxins, like urine mycotoxins, and also mold. There's various labs. When I ask practitioners what are their favorite labs, everybody says all the labs that are available. Everybody has a different favorite. They have a different reason why.
Sure.
So I don't even run those tests. It's not my area.
So you stay in your lane, send them out, fix that problem, and come back, and we'll start up again.
That's right. I mean, I can get someone going. I mean, I know the tenets of mold treatment, which include antifungals internally and in the nose. Binders is usually how they start. For SIBO, really the best binders are usually activated charcoal. There's pharmaceutical ones, there's chlorella, there's other ones, but some people with SIBO can actually, fermentable can be like the clays and things like that. So charcoal's best way to start, I think, for a SIBO patient with binders.
So things like bentonite clay or humic and fulvic acid.
Yes, people can bloat from those and have terrible reactions, and you could try them, but charcoal's the safest.
No, I'm thinking, well, that explains, and I'm thinking of the 3 or 4 patients I'm working with right now. That's
there
like
you
another,
go.
Clinical nugget. Yeah.
Yeah, all these fabulous, binder formulas, they are so amazing, and we have trouble with some SIBO patients. So binders, antifungals, and I know liver detoxification for mold. I know these tenets, but no, I don't.
Yeah,
it's
the
a specialty unto
yeah.
itself, especially with all the sensitivities and how slow you need to go with everything. So
yeah. All right, let's move on to the last thing, and that is the motility issue.
Oh, the prokinetics. Okay.
The prokinetics.
So prokinetics are simply agents that move the migrating motor complex. We already talked about how that's the main underlying cause for so many people. These could be pharmaceutical or nutraceutical or herbal. And key thing to know is that they're not laxatives. And another key thing to know is that an actual laxative doesn't stimulate the migrating motor complex. This is a big confusion for so many, including like prescription ones like Amitiza, Linzess. Those are prescription laxatives. They don't stimulate the migrating motor complex. It's just so important because many gastroenterologists don't know this, and they'll be like, well, I've given you a prokinetic. It's like, no, that is not stimulating the migrating motor complex.
Not a prokinetic, yeah.
So what are they? By the way, there are unsafe prokinetics. And so because of that, pharmaceutically, many doctors think prokinetics are unsafe, but we have safe prokinetics. So a safe prokinetic that we use, a really excellent one is prucalopride. In the US, that's called Motegrity. It's phenomenal. It has many beneficial side effects or effects like protects and heals nerves.
And that's a pharmaceutical or prescription?
It's a pharmaceutical.
Okay.
It's a pharmaceutical. It's prescription. It helps against tumors. It helps with cognition. It helps with depression. It's amazing. Safe. Incredible. Star in the prokinetic category. Then we have low-dose erythromycin. Erythromycin is an antibiotic, but at low dose, it is a prokinetic. And we have LDN. Low-dose naltrexone. It is not technically a prokinetic, but studies have shown it has prokinetic effects. It's anti-inflammatory, helps immune system. Amazing, right? Then on the over-the-counter, those are all prescription. On the over-the-counter, we have Iberogast, which is old-time German over-the-counter formula, herbal formula, 9 herbs. Now it's been changed to 6 herbs. Still good. Still studies coming out on that. It's good. And we have dupe formulas. So like on Amazon, there's IBS Shield, which is a dupe for the original 9 herb. Iberogast, it's excellent. Heron Botanicals has, I think it's Gut Motivator. It's also a dupe. So there's that. And this is a complex formula. It's not just the main ingredient, Iberosamara, that's doing the prokinetic effects. Studies have shown when they just check that one ingredient, no, it's the complex. Then we have ginger root. You could just take ginger root. And then now, luckily, we have all of these over-the-counter prokinetic formulas that include ginger. I call them the ginger-containing prokinetic formulas, like Motility Activator, ModalPro, Prokine, SIBO MMC. There's like 8 of them. One of them is like the one that's in Motility Activator is a patent of artichoke and ginger. It's a patented formula called ProDigest. And so like 5 brands carry it. Sometimes they'll have it with apple cider vinegar. So people with histamine intolerance need to watch out for that. But that one is less spicy on the ginger. Sometimes ginger can cause like ginger burn, almost like acid reflux. So I would choose the ones with ProDigest if that's a concern. And then there's a new one on the market that has bitter orange as its main prokinetic. Good animal studies on that as a prokinetic. No human trials yet, so we'll be the human trials. And that's by Gaia Pro. And I can't remember the exact name of it, but it's bitter orange based. So
do you find
options.
that they like one formula tends to work for everyone, or is it one of those things where you have
Absolutely not.
Yeah,
In fact, with prokinetics, I find prokinetics to be one of the most reactive categories that I've ever given. People in my experience, have a lot of reactions to prokinetics. And I sometimes have to go through, 6 of them, all 6 of the main ones, the 3 pharmaceuticals, the 3 main, over the counter. I'll have to go it's like sleep aids. And then, finally the last one you try is the one.
That's the one that works, yeah.
So don't give up on the category if people have reactions.
So so is it you're looking for an adverse reaction, or is there a good clinical sign that a prokinetic is working other than I'm not reacting to it?
This is the hard part. What is the benefit? That they don't relapse.
Okay.
So no, you're not going to feel or see anything. It's for preventative against relapse. What the studies show is by adding a prokinetic, you can extend the remission period by 4 times as much. 4, not double, but quadruple. Of course, that was pharmaceutical, but still. This is why we give it. Who wouldn't want 4 times longer remission period?
Sure. Yeah.
So that's why prokinetics are so important. So no, all we're looking for is how soon do they relapse? And once you really start treating a lot of SIBO, then you'll have a sense if you think it's too soon in that particular case with what their underlying cause is if they're a chronic patient.
Right.
And then you can do things like if they are relapsing sooner than you wish, of course, you just start tweaking. Like very often we'll use a prokinetic at night and in the morning, 2 different ones. Or we'll use the same one at night and the morning and add a second one at night. So now there's 2 at night, 1 in the morning, extra in the morning. So because all these prokinetics I mentioned have different mechanisms of action from each other. So it's fine to overlap them, except be careful with erythromycin and like domperidone. I didn't mention that one. Those can't go together, but pharmaceutically. Domperidone's hard to get anyway, which is why I didn't mention it. But so this is prokinetics. It's the one I think most, number one, I'd say, maybe number two, most common problem in SIBO treatment is someone was not given a prokinetic. And so after they finish their antibacterial, give them a day or so they can see how they feel, they need to go on a prokinetic.
So you don't dose that throughout the 4-week cycle?
Well, you can. Now because they're going to go on to further rounds, they can continue it through the next treatments.
But you don't introduce it until after the first round.
Yeah. And then the key thing is when, it doesn't matter if they take it during next rounds, the key is they need to be on it in between rounds and when they're done, when you're finished as a prevention.
Yeah.
And so that is what's missing in so many people's treatment. And it's just a terrible oversight.
Yeah. And like in the realm of prokinetics, I don't know how long ago, but I would say at least 7 years, there's been a lot of talk about vagal stimulation to, drive the vagal system and increase motility. My experience with that, because I play with that with clients, it's hit or miss. It works for some people, not for others. Same thing, whether it's, anxiety or depression or anything like that. Have you used that? What's been your experience and what's your opinion?
I tried a little bit of it long ago from what I learned from Dr. Karazian. And unfortunately, we didn't find much of any help. And it was very different from what Dr. Karazian was finding. He was reporting all these miracles and we were really bummed out because we just didn't see that at all. I still recommend, I think it's a fine idea. The thing is that there's two migrating motor complex. There's one that starts in the stomach and one that starts in the small intestine. The one that starts in the stomach is vagally mediated. The one that starts in the small intestine is not. And they don't even still fully understand all the instigating factors in that. But however, the one that starts in the stomach, from some of the literature I've read, that is supposed to be the stronger migrating motor complex. It starts in the stomach and goes through the whole small intestine. Maybe it's not. Maybe it's not. Maybe the one that starts in the small intestine itself is the more vital one to SIBO. Is that why the vagal stimulation has been maybe not as helpful as we wished? I don't know.
Yeah,
I still recommend it because it helps with so many things.
With some people, and other things, you're right. So one thing that I'm playing with lately, and it's way too soon for me to give an opinion on this, but do you know what the insular cortex is?
No.
Yeah, so
I probably should. I took all of Karazian's brain courses. I don't remember.
Well, let's call it a new lobe of the brain. Not that it's new; we never had it before, but like our understanding of it is actually a lobe of the brain. So, like when a baby is born, the baby has a massive neuron, so there's very little organization. And as the brain grows within the confined space of the skull, it starts to involute. It starts to fold in on itself. And just under the junction of the frontal, parietal, and temporal lobes, just around the temple, right above the ear, underneath this section, there's an infolding of the cortex, and that's what's called the insular cortex. And the insular cortex has a somatotopic representation. No, that's the wrong word. It has a viscerotopic representation. So in the brain, in the parietal lobe, we have a sensory homunculus, which is basically a map of the entire body as it relates to sensation. So if someone comes up and touches my shoulder, my brain shouldn't be confused and think that someone touched my ankle, right? So there's a picture of every body part in the parietal lobe on both sides so that we understand sensation. There's also a motor homunculus in the primary motor strip, which is a picture of every joint and muscle in the body. So when my brain says, hey, I want to wave my hand, I don't kick my foot out. There is a visceral representation in the insular cortex. And it's, in terms of neurological hierarchy, it's a couple of steps above the vagus, but it integrates with the vagus. And so my working theory right now, and that's all it is that when we have cases where vagal stimulation makes sense, perhaps in some of these cases, really what we're doing is we're stimulating the vagus to try to get activity in the insular cortex. Does that make sense? So sometimes I think in my theory, the cases where vagal stim works is that's the choke point, so to speak. And so the insular cortex might be fine, but something's decreased the frequency of firing of the vagal system. So you stimulate it directly, and now you get great things happening. But what if that system's intact and the problem's higher in the chain, if that makes sense? And so I'm playing right now with using different forms of transcranial direct stimulation to put electrodes over the insular cortex, trying to get the brain to understand the intestinal system better so that it can more efficiently organize signals going to and from that system. I'll let you know what happens.
Great. I'd love to hear.
Yeah. Yeah. So like I said, it's something recently that I've been playing with, and way too early for me to come out and say, yeah, this is what we need to be doing. But so far, so good. I'll say that.
Great.
Yeah. Yeah. Well, listen, you have been amazing and so generous with your time. This has been one of my favorite interviews. I tend to say that because I get a chance to talk to some really cool people who know things that I don't, and especially on the Func Med Nation podcast, where it's really geared towards practitioners. Like I know that I don't know everything, and it drives me crazy. I quite often joke it pisses me off that I don't know everything because I desperately want to. And so when I get to talk to people like you, who clearly, like, you are an expert in your field, and I so appreciate not just the facts and the details, but the clinical nuance. And I think you're just an amazing clinician. And I'm so very happy that you decided, yes, you're going to come on and have this chat with me. So whether it's clinicians or the general public, where can people find you?
Well, I have a free educational website. It's SIBOinfo.com, and it's for both patients and practitioners. It's been that way for, I don't know how long, since 2010 or something, I guess 15 years. And I don't see patients anymore, but I mostly just focus on education. And so I have courses. I have courses for patients and for practitioners. I've got a mini course for practitioners. I've got a testing masterclass, a testing mini course, and a comprehensive training for practitioners. And as I say, for patients as well. So you can see all that on my website. And also signing up for my newsletter is a great idea. I don't send too many. I know people can't stand getting too many things in their emails, right, but I often give free classes on SIBO. And when there's updates, I just update everybody. Like, for instance, about how TrioSmart started offering lactulose. I just sent an email about that. So, it keeps people in the know on practical things. And there's new research every year. The big gastroenterology conference just happened the weekend before we're recording this, DDW, and there's all brand new research. And I do an annual interview every year with Dr. Pimentel where we share all the new research. And so that's why I'd say if you sign up for my newsletter, you'll get included in that.
Yeah. And that's amazing that you play that role, because it's so easy as a practitioner just to put your head down and treat. And then you look up 5 years later and you realize that the clinical world has moved on and things have changed, and all of a sudden you're a dinosaur and you're doing things the old way, right? So I appreciate the fact that you've dedicated some of your time to not just stay up on the research yourself, but to share that with other people. And maybe we can use this as a parting question. Where is SIBO research going right now? What do you think is going to come out in the next year or so?
Well, there's always more coming out about treatments. So, I think like that NAC rifaximin compound thing will come out. And I think we're going to learn more about what's best to treat each of the different types of SIBO and those different organisms. I think we'll have probably new stuff in testing. I've been seeing articles coming through over the years with developing various capsules and various things like that. It'll be fascinating to see what we develop with that. But I think, and also just more on understanding the pathophysiology, we're going to see more with that. Like I said, we've gotten the bacteria figured out exactly. I think we're going to learn more about that. Some complicated things I didn't mention are there's these things called syntrophs. They're actually bacteria that sort of pre-make the gas that others make. I think we're going to see more on the pathophysiology. It's more on the microbiome aspect and how to treat that, I think.
Yeah.
That's one thing that's fascinating about SIBO is it's a current emerging field. Like, the research is being done now, and and when we first entered, it was being done, and it's being done now, and we are still learning. We do not have all of it figured out yet.
Yeah, and I love this whole field, because it's like, as a clinician, like, you have to evolve or die. No, that's a little extreme, but you know what I'm saying? Like things change all the time. And, I've been doing functional medicine now for not quite 20 years, but going close to that. And it's a totally different world than 20 years ago, right? The cases are different. The things I have to think about are different. The complexity is different. And maybe that's just because the more I know, the more I think about. I mean, that's entirely possible as well. I lied. I'm not done yet. I have one question.
Okay.
You talked about dosing the prokinetic at night and in the morning. That makes total sense, right? Do you ever, because I have done this, and again, I'm a little bit undecided on whether or not it's a good idea. Do you ever take your antimicrobials and give them a bolus right before they go to bed, maybe to take advantage of the slower transit time so it stays in the intestinal system a little longer? Or do you think that's, sounds good on paper, but practically that's not going to really do much?
Well, actually, what the studies show is that the migrating motor complex is most active at night when we're sleeping. And that's why we dose our prokinetics at night before bed. So in fact, I think the motility in the small intestine would be fastest at night.
Ah.
Right. So I think it makes more sense to take our antimicrobials breakfast, lunch, and dinner.
With food.
With food. Or they don't have to be with food, but in the day. Like during the day when we're eating meals.
Awesome.
Yeah.
All right. I promise I'm going to let you go now. But let me thank you again for being on the podcast, and you're welcome back anytime.
Well, thank you so much. Been a joy to be here.